Cardiovascular Part 2. The pulmonary artery catheter is also known as the Swan-Ganz catheter after Dr. Swan and Dr. Ganz, or as the flow-directed balloon-tipped pulmonary artery catheter. Its purpose is to evaluate your cardiac function, your circulating blood volume, and your response to treatment. Usually you use iced injectate with this if your cardiac output is extremely abnormal. And again, the patient should be supine or only slightly elevated to do this. And it takes an average of 3 different studies to do this. This is done in the acute care unit only. And this is what a Swan-Ganz catheter looks like. You've got your, this is the tip that goes into the pulmonary artery. This is where you inflate the balloon, and the balloon is located right here. And this is another one that shows it a little bit better and is also identified. You've got your thermistor for measuring your cardiac output. You've got your port for measuring your CVP, or for fluids. You've got your port for inflating the balloon, and the port for measuring your pulmonary artery and your pulmonary capillary wedge pressure. This is how the Swan goes in. Usually through the subclavian or the jugular. It'll go in through the superior vena cava. When you get into the right atrium, the balloon will be inflated, and then flow will direct it into the right ventricle and on up into the pulmonary artery. And it will continue until it lodges in a pulmonary artery, and then you will deflate the balloon. And these are the readings that you get that go along with it. The top one is your right atrial pressure. As you can see, it's fairly low. That's your CVP pressure. Then it goes into the right ventricle, and that pressure is a little bit higher. When it gets into the right into the pulmonary artery, you will see you have this dicrotic notchback, and that tells you you're in your pulmonary artery. So you can actually look at these 3 waveforms and know exactly where you are just by looking. The bottom one is your wedge pressure or your occlusive pressure. This is your pulmonary artery wedge pressure or occlusive pressure, and this is the same pressure basically that's in the left ventricle at the end of diastole, and is used to help identify volume overload or dehydration. This is how it correlates with your 12-lead ECG, and you can see we start off with a pulmonary artery pressure because we have a dicrotic notch, and then we go into a wedge or occlusive pressure. This shows the different values for pressures in the different areas. Your pulmonary wedge is between 5 and 15. Your PA diastolic, on the other hand, is 24/10. Your PA diastolic and your pulmonary wedge pressure should be about the same, plus or minus 2. But these are the different changes that you might have. Some different treatment modalities. You can have the intra-aortic balloon pump, which is also called counterpulsation. You have the IABP is inserted into the aorta and inflated during diastole, which is the opposite of what normally happens because you have diastole is rest, and this is for the heart. So this is inflated during diastole, so that pushes blood back into the coronary arteries, and it decreases afterload. It is used for patients who have cardiomyopathy or who have really sick hearts and need just a little bit of help there. Maybe they've had a massive infarct. Pacemakers can be temporary, and if they're temporary, they can be external, transvenous, or transthoracic. They can be permanent, where they're either transvenous or epicardial. They can be combined with an implantable cardioverter defibrillator, but the overall pacemakers are used to maintain a base rate, a base heart rate. That's all that it's done. It just maintains a base heart rate. A ventricular assist device can be of just the left ventricle, or it can be a dual chamber, which is the left and the right. It can be used as a carryover to transplant for a new heart, or it can be used as a terminal destination if they're not a candidate for a new heart. It can also be used to assist after a heart attack or a bypass surgery. And the different surgeries that might be done. You've got your Greenfield filter that is put in to prevent blood clots from traveling from the legs back to the lungs. You have an embolectomy where you remove a blood clot that might be causing a problem in the lungs or in the extremities. You've got your coronary artery bypass graft, which is the traditional form, and patients are in the hospital 4 to 7 days. Used to be 2 weeks, but now they're down to 4 to 7 days. Or you've got your keyhole type surgery, where they're in the hospital, they come in the day of surgery and go home like 36 hours later. It's considered basically outpatient surgery. And with the keyhole surgery, you've got a computer that's involved. You have percutaneous transluminal coronary angioplasty, or percutaneous transluminal angioplasty. So it could be PTCA of the coronary vessels or PTA of other arteries, where you take plaque and squish it out along the arteries and open up that artery. An atherectomy is where they go in and use like a rotor and remove that plaque that's causing the problem. A myomectomy is where they cut out part of the heart muscle, making the heart muscle smaller, and that has been shown to increase contractility. Remember Starling's law: when the heart is way too big and boggy, it doesn't contract well, where if you can make it a smaller chamber, it does contract well. And of course we have transplants, which we'll talk about in a little bit. We also have a temporary implanted artificial heart that can be done. The Cleveland Clinic is developing an implantable electric heart pump similar to a biventricular VAD. And they're doing this because we need between 25 and 50,000 hearts a year to replace. And in 2003 they did 2,400. So you need to have more help. Then we have all the medications, which we will talk about later, but the statins are really important. They cut your LDL in half, and they decrease death and disease by 1/4 to 1/3, and statins are sold over the counter in Europe. There's a new investigational drug that's out there that's given IV that increases your HDL. Now it costs about $4,000, but for each point you increase your HDL, you decrease your risk by 3%. And you can take niacin over the counter to increase your HDL, but you have to take 2 to 3 grams a day, and that causes flushing and itching that can be very severe. This is what an intra-aortic balloon pump looks like, or counterpulsation. It's inflated during diastole and deflated during systole. It decreases afterload and increases the blood supply to the heart itself. This is showing you a pacemaker. The leads are usually bipolar, so that if one cracks, the other one still works. And they're usually ventricular, but you may have one that is arterial in the atria as well as the ventricle, so that's an AV sequential pacemaker. We also have an implantable cardioverter defibrillator that is put in. And now they will also have pacemakers with them if necessary. This is showing on the far left atrial pacing, which is rarely done by itself. You've got your ventricular pacing that's often done by itself. And if you have somebody who's a young person, they'll do the AV sequential, because you want to make sure that they are getting... You do an AV sequential if you're afraid that they're going to lose that atrial kick. Because when the atria don't contract well, you can lose up to 20 to 25% of your cardiac output. And that could be significant for some people. So you want to make sure that they have an adequate contractility and that they don't lose their cardiac output by that quantity. And this is showing a pacemaker rhythm. Now, they never have those lovely little X's over the pacing spike. And the pacing spike can either be positive, as this is, or negative, which means it goes below the line. But you'll notice that the third complex shows an AV sequential, because I've drawn in a pacing spike before that P wave. And that's what you would see if you had somebody who had an AV sequential. You would see a pacing spike before the P's as well as before the QRS's. But since they are determined based on rate and intervals, you don't always see a pacing spike before everything, unless it is totally dependent upon the pacemaker in order to function well. This is showing someone who has an underlying atrial fib and has a paced rhythm. If you look very closely, you can see the pacing spike here. Sorry. And here. And there. And this little tiny one there. So those show you your pacing spikes. And then he goes back to his atrial fib because his rate gets higher. We really don't have a non-surgical pacemaker, but this was a close-to-home cartoon that was in there. And he says, they tell me it's the latest breakthrough, the non-surgical pacemaker. This is what someone looks like who wears a VAD. Now, the VAD itself is totally implanted, but then these tubes come out and go to the generator or go to the battery. And they have to wear about 8 batteries. And the batteries are good for a couple, 3 hours, and they have to be changed. And you wear them continuously so that if you have somebody who has a hearing problem, you make sure they don't lay on their good ear because it will buzz when a battery needs to be changed during the night. And some of the other things you might do, you might want to grow new arteries. And this is where a catheter is threaded into the heart and tiny growth factor capsules are implanted into the wall to spur the growth of new blood vessels. And then we have our standard bypass surgery. It shows where they go out on the heart-lung machine and then they do the bypasses over the blockages that are there. They also have off-the-pump bypass that they can do nowadays in addition with the keyhole surgery. And this is showing drop the heart-lung machine or off-the-pump coronary artery bypass, where you open the chest like you do for an ordinary one, but you operate on the beating heart with help of instruments that hold portions of the heart steady. And this is where you punch new channels into the myocardium and use a laser tip catheter to that blood-starved area. Drill quick blasts from the laser drill, 30 or more tiny holes, most of the way through, and then the damaged tissue will seem to stimulate, for some reason, new blood vessels. And that seems to work better. And they also can zap the plaque with radiation. As a supplement to angioplasty, tiny radioactive pellets are sent through the catheter to the blockage and held in place for several minutes. The radiation inhibits scar tissue that could result in new blockages. And this is showing find the true culprit, where you have fatty deposits within the coronary artery walls that can cause more heart attacks and blockages in the artery's interior. Magnetic resonance imaging, or MRI, or an ultrasound probe slipped into the artery can spot the deposits, and then drugs can halt their growth or even shrink them. And this is showing PTCA, where you have the patient who's going to have the angioplasty. The catheter is inserted oftentimes in the far left. It shows using the femoral artery and goes up into the heart to the area of blockage. And you can see number 2 shows the blockage, and then they have a tiny balloon that's inflated, squashing the fatty plaque against the arterial wall. And then oftentimes they'll put in a stent. Now, they were using drug-eluting stents that were to try and prevent restenosis. There's been some problem with that lately, so they may not be using the drug-eluting stent, just a regular stent. It depends. And here's looking at some of the different stents. This is a multi-link vision coronary stent on the left, and it's showing it deployed in the artery on the right. And this is a power sail where the catheter piece, the tip is going toward you on the left, and then the sail is on the right, and that's an inflated balloon. And this is then showing the drug-eluting stent, because the drug is coming off of that. As a possibility. And here's another cartoon to end this portion of the lecture, and it shows Ted's coronary angioplasty goes horribly wrong. And instead of having the balloon in the heart, it's coming out of his ear. And if you notice, Ted's awake, and they always are awake during the angioplasty or cardiac cath, and so it's something that you need to be aware of. You need to make sure your patient gets a little bit of sedation, and this has never really happened, so we don't have to worry about that, but it's kind of a cute cartoon.